Morning everyone. Today we shall be talking about the topic chronic inflammation and granulomatous inflammation. Coming to definition and the causes, inflammation is defined as the local response of living mammalian tissues to injury from any agent. The injurious agents which can cause inflammation may be infective agents, immunological agents, physical agents or chemical agents or inert materials. Infective agents include the bacteria, virus and their toxins, fungi, parasites, etc. Immunological are usually the cell mediated and antigen antibody reactions. Physical elements might be that heat, cold, radiation, mechanical trauma. Chemical agents may be organic or inorganic poisons. Inert materials include the foreign bodies. Coming to the definition and the causes, chronic inflammation can be defined as the prolonged process in which tissue destruction and inflammation occur at the same time. It can be occurred by three following ways. Number one is the following acute inflammation, when the tissue destruction is extensive or the bacteria survive and persist in small numbers at the site of acute inflammation. Example in osteomyelitis, pneumonia terminating in lung abscess. Number 2 is the recurrent attacks of acute inflammation, when repeated bouts of acute inflammation culminate in chronicity of the process, like example in recurrent UTI, which leads to the chronic pyelonephritis, repeated acute inflammation of the gallbladder leading to the chronic cholecystitis. Then comes the chronic inflammation starting de novo, when the infection with organisms of low pathogenicity is chronic from the beginning, that is like example infection with Mycobacterium tuberculosis. Now coming to the general features of the chronic inflammation, first is the mononuclear cell infiltration. Chronic inflammatory lesions are infiltrated by mononuclear inflammatory cells like phagocytes and lymphoid cells. Phagocytes are represented by circulating monocytes, tissue macrophages, epithelial cells and sometimes multinucleated giant cells. On activation, the macrophages release several biologically active substances like acid and neutral proteases, oxygen-derived reactive metabolites and cytokines. These products bring about tissue destruction, neovascularization and fibrosis. Other chronic inflammatory cells include lymphocytes, plasma cells, eosinophils and mast cells. Now coming to the second, that is the tissue destruction or necrosis. Tissue destruction and necrosis are central features of the most forms of the chronic inflammatory lesions. It is brought around by the activated macrophages, which release the biologically active substance like protease, elastase, collagenase, lipase, active oxygen radicals, cytokines, nitric oxide, angiogenesis, growth factor, etc. Coming to the proliferative changes, as a result of necrosis, proliferation of small blood vessels and fibroblasts is stimulated, resulting in formation of inflammatory granulation tissue. Eventually, healing by fibrosis and collagen takes place. Then comes the systemic effects of the chronic inflammation. Chronic inflammation is associated with the following features like fever, anemia, leukocytosis, ESR and amyloidosis. Fever, invariably there is mild fever, often which there is loss of weight and weakness. Anemia, chronic inflammation is always accompanied by anemia of varying degree. Leukocytosis, as in acute inflammation, chronic inflammation also has leukocytosis, but generally there is relative lymphocytosis in these cases. ESR is elevated in all cases of chronic inflammation. Amyloidosis, long-term cases of chronic suppurative inflammation may develop secondary amyloidosis. Types of chronic inflammation, two types: chronic non-specific inflammation and chronic granulomatous inflammation. Coming to chronic non-specific inflammation, when the irritant substance produces a non-specific chronic inflammatory reaction with formation of granulation tissue and healing by fibrosis, it is called chronic non-specific inflammation. Examples are chronic osteomyelitis, chronic ulcer, lung abscess. Then comes the chronic granulomatous inflammation. In this, the injurious agent causes a characteristic histologic tissue response by formation of granulomas, like example of tuberculosis, leprosy, syphilis, actinomycosis, sarcoidosis, etc. Now we shall talk about the granulomatous inflammation. Granuloma is defined as a circumscribed tiny lesion which is about 1 mm in diameter, composed predominantly of collection of modified macrophages called epithelial cells and rimmed at the periphery by the lymphoid cells. The word granuloma is derived from granule, meaning the circumscribed granule-like lesion, and oma, which is suffix commonly used for true tumors, but here it indicates a localized inflammatory mass or collection of macrophages. Pathogenesis of granuloma. Formation of granuloma is a type 4 granulomatous hypersensitivity reaction. Example: Mycobacterium tuberculosis, Mycobacterium leprae, suture material, particles of talc, etc. Here, this is the mechanism of evolution of granuloma. First, there is cell injury. Example: by the Mycobacterium tuberculosis or talc particles. There is a failure to digest the agent, which causes weak inflammatory response. Then there is engulfment by macrophages, and there is persistence of injurious agent causes T cell mediated immune response or poorly digestible agent. Activation of the CD4 T cells and release of lymphokines along with monocytic chemotactic factor. There is accumulation of the tissue macrophages and there is proliferation of T cells, which in turn the macrophages are activated by IFN gamma, which causes the transformation to epithelioid cells or giant cells and secretion of fibroblast proliferation. Cytokines or tumor growth factor are also seen, which ultimately leads to the granuloma formation here. Coming then first, engulfment by macrophages. Macrophages and monocytes engulf the antigen and try to destroy it, but then antigen is poorly degradable and it fails to get digested, and degrade is undergo morphologic change to form into epithelioid cells. CD4 T cells get activated along with the activation of the lymphokines. Then comes the cytokines, where various cytokines activated CD4 T cells are seen. Interleukin 1 and 2 stimulate the proliferation of more T cells. Interferon G activates macrophages. And tumor necrosis factor alpha promotes the fibroblast proliferation and growth factors. Now, composition of granuloma. In general, granuloma has the following structural compositions like epithelioid cells, multinuclear giant cells, lymphoid cells, necrosis, and fibrosis. Coming to the epithelioid cells, these are so called because of their epithelial cell-like appearance. They are modified macrophages or histiocytes, which are somewhat elongated cells having a slipper-shaped nucleus. This nuclear chromatin of the cells is vesicular and slightly staining, while the cytoplasm is abundant and pale staining with hazy outlines, so that the cell membrane of the adjacent epithelioid cells is closely opposed. Epithelioid cells are weakly phagocytic. Coming to the multinuclear giant cells, these are formed by fusion of adjacent epithelioid cells and may have 20 or more nuclei. They may be arranged at the periphery like the shoe horse or as a ring, or may be clustered at two poles like Langhans giant cells, or they may be present centrally foreign body giant cells. The former are commonly seen in tuberculosis, while the latter is common in foreign body tissue reactions. Like epithelioid cells, these giant cells are weakly phagocytic but produce secretory products which help in removing the invading agents. Then comes the lymphoid cells. As a cell-mediated immune reaction to the antigen, the host response by lymphocytes is integral to composition of a granuloma. Plasma cells indicative of accelerated humoral immune response are present in some types of granuloma. Coming to necrosis, it may be feature of granulomatous conditions like central caseation necrosis in tuberculosis, so called because of the dry cheese-like appearance. Then comes the fibrosis. It is a feature of healing by proliferating fibroblasts at the periphery of the granuloma. The classical example of granulomatous inflammation is the tissue response to tubercle bacilli, which is the tubercle seen in the tuberculosis. A fully developed tubercle is about 1 mm in diameter with central area of caseation caseating necrosis surrounded by epithelioid cells and then onto several multinucleated giant cells, commonly the Langhans type of giant cells. And then it is surrounded by a periphery at the periphery by lymphocytes and bounded by fibroblasts and fibrous tissue. This is the morphology of tubercle, where caseating necrosis, epithelioid cells, Langhans giant cells with multiple nuclei and lymphocytes are seen. Then the periphery will show some lymphocytes too here. Coming to the examples of the granulomatous inflammation, granulomatous inflammation is typical of reaction to poorly digestible agents elicited by tuberculosis, leprosy, syphilis, fungal infections, schistosomiasis, foreign body particles, etc. Now, some principal granulomatous conditions like bacterial, which includes tuberculosis, leprosy, syphilis, granuloma inguinal, brucellosis, cat scratch disease, tularemia, glandus. Here are the etiological agents of each and the special characteristics. Coming to the first one, that is the tuberculosis, the characteristics are the tuberculous granulomas with central caseating necrosis and acid-fast bacilli. Then comes leprosy, which shows foamy histiocytes but acid-fast bacilli, epithelioid cell granulomas. Then comes the syphilis, gammas composed of histiocytes, plasma cell infiltrations and central necrosis. Then comes the granuloma inguinal donovenosus, where anal and genital lesions will be there along with macrophages and neutrophils showing the Donovan bodies. Then comes brucellosis, where dairy infection to humans, enlarged reticuloendothelial organs are seen. Cat scratch disease is seen, where lymphadenitis, reticuloendothelial hyperplasia, granuloma with central necrosis and neutrophils are seen. Tularemia, where necrosis and separation, tubercles hard or with minute central necrosis are seen. Then comes the fungal, which includes actinomycosis, blastomycosis, cryptococcus and coccidomycosis. Then comes the actinomycosis, cervicofacial, abdominal, thoracic lesions, granulomas and abscess with draining sinus and sulfur granules are seen. Blastomycosis, cutaneous, systemic and lung lesions, separation is seen, ulceration and granulomas are present. Cryptococcus, meninges, lungs and systemic distribution will be present. Organism is used like with cleared capsule. Coccidomycosis, it meninges, lungs and systemic distribution. Granulomas and abscess with organism containing endospores. Then coming to the parasite, which comes the schistosomiasis. Eggs and the granulomas will be present in the gut, liver and lungs. Schistosome pigment will be present. Eosinophils will be present in the blood and the tissue. Some miscellaneous diseases are given, like which includes the sarcoidosis, Crohn's disease, silicosis, berylliosis and foreign body granulomas. In sarcoidosis, non-caseating granulomas are present, which has hard tubercles. Asteroid and Schaumann bodies in giant cells are seen. Crohn's disease, transmural chronic inflammatory infiltrates, non-caseating sarcoid-like granulomas are present. Silicosis, lung lesions, fibrocollagenous nodules are present, and berylliosis, sarcoid-like granulomas in lungs, fibrosis, inclusions in the giant cells, and which are like asteroids, Schaumann bodies, crystals are present. Coming to the foreign body granulomas, non-caseating granulomas with foreign body giant cells are present, and there is demonstration of the foreign body. This is a basic table which is showing the differences between the acute and the chronic inflammation. The first feature, onset and duration, which is like acute has occurring within the short time and it lasts for short duration. Chronic has after delay and lasts longer. Coming to the cardinal signs, it's invariably present in acute and generally imperceptible in the chronic type. Coming to pathogenesis, acute inflammation has vascular events which are hemodynamic changes, increased vascularity, cellular events like exudation of leukocytes, phagocytosis, and role of chemical mediators and regulators. In chronic type, we have it is of usually three steps like following the acute inflammation, recurrent attacks of acute inflammation, and chronic inflammation from the beginning itself. Then comes the main inflammatory cells, which are neutrophils, eosinophils, lymphomononuclear cells, and pus cells in the acute type, lymphocytes, plasma cells, monocytes, macrophages, and giant cells in the chronic. Plasma exudation is present in the acute type, may or may not be present in the chronic type. Systemic effects: fever is of high grade, leukocytosis is present, eosinophilic and neutrophilic, lymphadenitis and lymphangitis will be present, and septic shock in severe acute infection. In the chronic type, we can see fever is of the mild intensity, leukocytosis will be present, which is lymphocytic or monocytic, lymphadenitis, lymphanginitis will be present, raised ESR, anemia, amyloidosis in long-term cases. Coming to the main morphology, abscess, ulcers through blood, which is like bacteriemia, septicemia, etc. Resolution, healing, are seen in the main morphology. Then comes the chronic non-specific inflammation, granulomatous inflammation are present. Coming to the fate in the acute type, resolution, healing, and chronicity is present, and healing has two steps, that is regeneration and fibrosis. In the chronic type, resolution, healing, and dystrophic calcification comes, where healing also has the same two phases like regeneration and fibrosis. Some common examples of acute inflammation are pyogenic abscess, cellulitis, bacterial pneumonia, and pyemia. But in the chronic inflammation, we have granulation tissue, granulomatous inflammation, tuberculosis, leprosy, and chronic osteomyelitis. Thank you for today.